In this episode, we're going to talk about the shoulder block and what is the best shoulder block to do for shoulder surgery. Let's try that again. Sorry.
Hi, I'm Stuart.
And I'm Jeff.
Welcome to Walk Around the Block.
And in this episode, we're going to talk about how to give great regional anesthesia for shoulder surgery. And, we typically choose one of a couple of blocks that are traditional good blocks for shoulder surgery, but they don't always work in every situation.
No, there are some patients where there are coexisting conditions that make us anxious with the usual go-tos. So, another episode we talked about which block we do. You talked about loving interscalene. I said an alternative, the more recent alternative is superior trunk. But I think
great options. Yeah.
Both great options, but I am equally anxious with either one if I've got an obese patient with COPD.
Yeah.
And I'm worried that I'm going to knock out the phrenic nerve. So how often is the phrenic nerve block knocked out with these?
Traditionally we always said 100%. And I think we have to assume that. Even with small volumes, we see that leakage up and over the anterior scalene. So we make that assumption anyway. I think it's prudent to do that.
Mm-hmm. And so there are very few patients where you're going to worry about that. But, I get a few patients that slip through the net at pre-op screening. Now we're doing more telehealth visits, and patient arrives in and you think, okay, maybe an interscalene isn't a good idea here. Now, I think there's two scenarios. One where I'll end up doing a superior trunk or interscalene, but I might change my practice. And the other one where I might use an alternative. So let's talk about things we can do with the interscalene to make things maybe not as bad. And one you can do is go a little bit further down the neck. And maybe the patient might not be as breathless.
Right, for sure. So the more you get down the brachial-plexus, the less chance you have of getting that phrenic nerve. So supraclavicular block, you're looking at 50-60% of the time, probably. Infra, virtually zero. Although you're going to miss some of the elements like the suprascapular nerve. So I think a supra is a nice compromise, although it's not going to still have that risk of.
I'm still worried.
I'm still worried.
In some of these patients, it's still, I think, a no-go.
Yeah. So what I tend to do is we'll put a catheter in and we'll put a bit of short-acting local anesthetic, either mepivacaine or lidocaine or chloroprocaine, and see if they fly afterwards. And if they do get into respiratory embarrassment, one of my favorite phrases in medicine, by the way, then
okay.
It sounds better with a British accent. Respiratory embarrassment.
Yeah.
Then you've only bought yourself a couple of hours of that, and you can sort of mitigate that. And
I'll do that in pre-op, knowing I'm going to take the patient back, and hey, in a second or two, I can have a tube down. And if I use chloroprocaine, the speed of the surgeons I work with for a shoulder joint, well, it's gone by the end of the case. So you can see, how the patient respond. Do you feel more breathless, sir or madam? And if it's a bad scenario, you can take it out. I've tried to flush the catheter with saline. I read some old papers about reversal of epidurals by flushing with saline.
Yeah.
And a couple of times I have patients who've had maybe a too dense a block that people want to examine, and I've never managed to reverse the original block. No, I was still like, put the tube in and on we go. But I'd read that for epidurals, but not had that success with peripheral nerve catheters. But yeah, that's one. The other is is to use a very, very, very small volume. Colin McCartney polished a paper and he said with as low as 3 cc's. So just think about this. The normal practice before ultrasound was 35, 40 cc's, the interscalene groove. If your patient didn't need to go up 2 shirt sizes, you weren't doing it properly.
We used to look Look for the swelling, the sausage, under the skin.
Oh, that, you're definitely working with this massive swelling. But with ultrasound, you can place a very, very small volume. Now, you won't get the duration.
Yeah.
But if you get a catheter in, that's not such a problem.
Yeah.
The other thing in a catheter, use a short-acting local. Traditionally, we'll use bupivacaine or ropivacaine, but use a shorter-acting medication like mepivacaine. So if you do run into problems, it's going to be of a shorter duration. Yeah.
Yeah.
So what about alternatives? So that's the kind of managing an interscalene.
Yeah.
What about alternatives?
So I think, if you look at the anatomy of the shoulder joint, 70% or so is innervated by the suprascapular nerve. So if you had to do just one alternative nerve block, that'd be it. And there are certainly lots of, a handful of studies now looking at comparisons between interscalene and suprascapular, and they seem to be roughly equivalent in terms of at least post-operative pain. Mm-hmm. I don't think you could get surgical anesthesia with just suprascapular alone, but most of the time we're looking for post-operative pain.
And I do a lot of rotator cuff repairs on the block alone. So what we're talking about here is definitely alternatives for post-op analgesia. Suprascapular.
Right.
It's like the toilet roll holder, front or back. Anterior or posterior.
Yeah, I gotta say, I do like the posterior approach. I think that a couple of reasons. One is the anterior. I'm not convinced that you're going to avoid any spread back to either the phrenic or the rest of the brachial plexus. I think with any considerable volume, it's just going to track back along those pathways. I also think that despite how heavy a person is, you get a pretty good image of the suprascapular fossa and the right probe angle. And it's easy to come down, contact the bone. I'm not going into the notch. I'm just contacting the bone just lateral to the notch. Yeah. And putting the local there.
So the advantage of the anterior, David Ayung, our friend David, would argue that the advantage of the anterior is that you will get the brachial plexus, and if you actually look at the anatomy, that it's close to the posterior cord and close to what will become the axillary nerve. And so he says that's the advantage. The disadvantage is, we talked about those challenging patients with COPD and obesity. I'm worried that they will not breathe properly. I've still got the chance of having some sort of phrenic nerve dysfunction afterwards. So yes, it's a great approach, and that paper that David published in anesthesiology with interscalene and anterior approach, that it really didn't seem to be much difference. But it does, the suprascapular nerve is responsible for part of the shoulder, but there's a lot more to innervation of the shoulder joint than just that. Do you ever block the axillary nerve? So not an axillary brachial plexus block, but the axillary nerve. It's going to be your help you abduct your shoulder and supply your deltoid.
Yeah, and that's actually our alternative plan much of the time is we'll sit the patient up, we'll put the probe in just over the suprascapular fossa, over the scapular spine, do the suprascapular nerve block, put the probe around to the posterior part of the humerus, do an axillary nerve block, and then call it a day.
Yeah, and Darcy Price, a real innovator, was the first person to describe this, and his case series, he talked about when those two blocks were off that the rebound wasn't so high. He seemed to think it was a different effect from, you had some breakthrough pain maybe from the subscap, that you gave them some analgesics, and it meant that the step down wasn't like stepping off a cliff, because it didn't block all the plexus. You're also missing the superficial cervical plexus, which is responsible for the skin. And when the suprascapular nerve gets most of the rotator cuff but doesn't get the nerve to subscap, I do a little bit different. I'll actually do an infraclavicular along. So my alternative is actually to do the subscap. I'll do it posterior, make sure I'm out of the way, and then also do an infraclavicular brachial plexus block. And I aim for the posterior cord, although I usually end up getting the whole plexus.
Because you're that good.
No, I've just got no way of controlling it.
Do you put a lower volume in? Try to get that.
I haven't tried to be too clever, because I don't know what the the lower volume that'll work.
Yeah, yeah.
And to be honest, your medial to lateral, what is going to be
Yeah.
the posterior cord? I'm not sure if it's acoustic enhancement behind the vessel
Yeah.
or as a posterior cord. So I just put in a big volume and go for it, because you don't need a large volume for the suprascapular nerve. But so yeah, if we're going to give you the tips for the end, is going to be, we're both going to go for a posterior suprascapular nerve block. Make sure we
Yeah.
avoid the phrenic, and then combine it with the auxiliary nerve block, or even try an intraclavicular. But those are the two tips in these patients, and you don't regret doing that.
No.
You might regret going for the interscalene and just trying to wing it.
Absolutely.
Yeah.
Yeah. And we it's about 2 to 5% of patients in our practice that we end up shunting down this pathway because I just don't want to get close to that phrenic.
Yeah.
And so, well, let us know what your thoughts are. What do you use? What do you do when you encounter the situation? Email us at walkaroundtheblock@gmail.com, and we'll see you next time.
Bye-bye.